Welcome to episode 8 of Novamind's Master the Beat series from Basic ECG to ACLS. I'm Mal, a critical care provider and ECG ACLS instructor with over 15 years of experience in training thousands of medical professionals. In today's episode, at the Crossroads, the World of Junctional Arrhythmias, I'll share my top tip for quickly analyzing ECGs focusing on junctional arrhythmias. Let's get started. Welcome to Novamind's Master the Beat, from Basic EKG to Life-Saving ACLS. Let's embark on this journey together and master the beat. Now back to our junctional arrhythmias. These arrhythmias occur at the junction between the atria and ventricles, the atrioventricular or AV node area, and can be a bit tricky to recognize at first glance. By the end of this episode, you will have a good grasp on junctional arrhythmias, what they are, why they occur, ECG characteristics, and their clinical significance. In this episode, we will review junctional rhythm, accelerated junctional rhythm, paroxysmal junctional tachycardia, and premature junctional contraction. Before we move on with junctional rhythms, it's crucial that we understand the monumental impact of the Human Genome Project, completed in 2003. This groundbreaking international effort mapped all 3 billion base pairs of human DNA and identified around 25,000 human genes. The Human Genome Project not only deepened our understanding of human biology, but it also revolutionized healthcare by revealing that the genetic basis of diseases and diversity. Let's go over some of the myths debunked by the Human Genome Project. Myth number 1: race is a biological concept with distinct genetic differences. In reality, the Human Genome Project revealed that the concept of biologically distinct racial groups is false. Before the Human Genome Project, many believed that humans could be divided into biologically distinct races with unique genetic traits. This belief was rooted in racial essentialism. Racial essentialism is the belief that race is a biological, determined, and unchangeable trait, and that people of different races possess inherent characteristics or abilities based on their race. This idea falsely assumes that racial differences are rooted in biology rather than shaped by social, historical, and environmental factors. The roots of racial essentialism date back to the colonial era, where it was used to justify slavery, colonization, and racial hierarchies. It reinforced discriminatory practices by promoting the idea that certain races were inherently superior or inferior based on biological traits. This belief has persisted for centuries, influencing fields like medicine, where it wrongly shaped views on health and disease. To be clear, all human beings share 99.9% of their DNA. The small percentage of variation between individuals does not correspond to racial categories. Most genetic variation, about 85 to 90%, occurs within these so-called racial groups rather than between them. This means that two people from the same race can be more genetically different from each other than either is from someone considered to be of a different race. This finding confirmed that race is a socially created concept, not a biological category. While traits like skin color, eye shape, or hair texture are inherited, they do not indicate significant genetic differences between races. These traits are influenced by a very small number of genes, which reflect environmental adaptations rather than any meaningful division of the human species into races. Now back to our junctional arrhythmias. Cardiac cells in the AV junction area possess automaticity, which is the inherent ability to spontaneously generate electrical impulses without external stimulation. This means they can initiate impulses and control the heart rhythm independently. Let's begin by reviewing the junctional rhythm. Junctional rhythm is not a common arrhythmia. It occurs when the AV junction acts as the heart's backup pacemaker. This occurs when the sinus rhythm, the primary pacemaker, drops below the AV junction's inherent rate of 40 beats per minute. The junction step in to take over, resulting in junctional rhythm. Conditions like an inferior wall MI or ditch toxicity are often associated with the onset of junctional rhythm. Typically, the SA node is responsible for initiating the electrical impulse that leads to heartbeats. However, when the AV junction becomes the pacemaker, the electrical activity follows a different pathway. It's essential to note that junctional rhythms can appear similar to both accelerated junctional rhythm and junctional tachycardia on an ECG. The key difference between them is the heart rate. Junctional rhythm occurs when the heart rate is between 40 to 60 beats per minute. Accelerated junctional rhythm takes place when the heart rate speeds up to 60 to 100 beats per minute. Junctional tachycardia refers to a heart rate exceeding 100 beats per minute. Now let's focus on the junctional rhythm and its P wave. Understanding the variations in the presentation of P waves in junctional rhythms is crucial to making accurate interpretations in clinical practice. In junctional rhythm, when the AV node fires, the depolarization wave spreads in two directions: retrograde into the atria and antegrade into the ventricles. This retrograde conduction is why the P wave appears inverted in lead 2. The electrical signal is traveling upward from the AV junction to the atria, which is the opposite of what we would see in sinus rhythm, where the impulse starts at the SA node and travels downward. The QRS complex, however, remains positive in lead 2, because in both junctional and sinus rhythm, the impulse continues to travel downward through the ventricles, which results in a positive deflection on the ECG in lead 2. Now let's break down how this can present on an ECG. If the atria depolarize first, the P wave will appear before the QRS complex, but because the depolarization is retrograde, the P wave is inverted and will have a short PR interval. If the ventricles depolarize first, the P wave will appear after the QRS complex, also inverted because of the retrograde atrial depolarization. If both the atria and the ventricles depolarize at the same time, the P wave will be hidden within the QRS complex and may not be visible at all on the ECG. Despite these changes in the P wave, in all cases, the QRS duration remains normal because ventricular depolarization is proceeding in the usual manner through the bundle branches. As a helpful reminder, think of depolarization as contraction. When you see the P wave, it represents the atria being stimulated to contract, and the QRS complex represents the ventricles being stimulated to contract. Now let's do a junctional rhythm practice strip. Starting with the rhythm is regular, meaning that the R-to-R intervals are consistent throughout the strip. Next, the heart rate. The heart rate is 40 beats per minute. When I look at my strip, I see 4 QRS complexes within my 6-second strip. When I times that by 10, I get 40. P wave. The P wave is not visible because it is hidden within the QRS complex. This is a common characteristic of junctional rhythms when the atria and the ventricles depolarize at the same time. Next is the PR interval. There is no measurable PR interval because the P wave is not visible. Next, our QRS complex. The QRS complex is normal in duration, indicating that the ventricle depolarization is functioning properly and that this impulse is being conducted through the ventricles without delay but initiated above the ventricles. In summary, this is a junctional rhythm with a rate of 40. The absence of a visible P wave and a regular rhythm are key indicators. Now let's look at the junctional rhythm and ACLS. Junctional rhythm typically does not require treatment if asymptomatic. If the heart rate is too slow and the patient is symptomatic, use ACLS bradycardia algorithm. Atropine can be administered to increase the sinus rate and help suppress the junctional focus, allowing the SA node to regain control. In cases where atropine is ineffective, or if the patient is critically symptomatic, temporary pacing may be required to maintain an adequate heart rate and ensure sufficient cardiac output. Also consider starting a dopamine or an epinephrine drip. It is important to identify and address the underlying cause of junctional rhythm. Causes may include those electrolyte imbalances, myocardial infarction, medication toxicity, or vagal stimulation. Correcting these issues can often resolve the rhythm disturbance. Now let's talk about premature junctional contractions. A premature junctional contraction, or a PJC, is an early heartbeat that originates from the atrioventricular junction rather than the sinus node. It occurs when the AV junction takes over as the pacemaker of the heart, causing premature beat. PJCs are typically characterized by their inverted or absent P waves on the ECG as the depolarization travels retrograde to the atria. A normal QRS complex, since the ventricular depolarization occurs normally, you will see a shortened PR interval or P waves that can appear before, during, or hidden or after the QRS complex, depending on the timing of the atrial and ventricular depolarization. PJCs can occur in healthy individuals, but are more commonly seen in patients with conditions like heart disease, ischemia, or electrolyte imbalances. These contractions may also be triggered by stimulants like caffeine or certain medications. Premature junctional contractions are relatively uncommon. They can occur as isolated beats or follow a specific pattern, such as occurring every second beat, bigeminal pattern, every third beat, trigeminal pattern, every fourth beat, quadrigeminal pattern, or in pairs or runs of 3 or more beats. PJCs are typically caused by an increased automaticity of the atrioventricular junction. Certain factors and conditions are linked to the development of PJCs, including the consumption of caffeine, alcohol, or tobacco, as well as electrolyte imbalances. Additionally, inferior wall myocardial infarction, MI, which disrupts blood flow to the AV node, and ditch toxicity can contribute to the occurrence of PJCs. PJC frequency and symptomology. Premature junctional contractions have clinical relevance that varies depending on their frequency, underlying cause, and the patient's overall cardiac health. While isolated PJCs are often benign and may not produce noticeable symptoms, their presence can indicate underlying cardiac conditions that warrant further evaluation. Occasional PJCs may not cause any symptoms and are often discovered incidentally on ECG, when frequent PJCs can lead to palpitations, dizziness, or sensations of a skipped heartbeat. In some cases, they may precipitate more serious arrhythmias, especially in patients with structural heart disease. PJC ECG characteristics. Inverted or absent P waves on the ECG as depolarization travels retrograde to the atria. They will have a normal QRS complex since the ventricular depolarization occurs normally. You'll see a shortened PR interval or P waves that can appear before, during, hidden, or after the QRS complex, depending on the timing of the atrial ventricular depolarization. Our next junctional arrhythmia will be called accelerated junctional rhythm. An accelerated junctional rhythm originates from the ectopic pacemaker site in the AV junction and occurs at a rate of 60 to 100 beats per minute. The term accelerated refers to the fact that this rhythm is faster than the normal junctional rate of 40 to 60 beats per minute, but it does not meet the threshold to be classified as a junctional tachycardia, which is greater than 100 beats per minute. Like regular junctional rhythm, on the ECG, accelerated junctional rhythm is regular and continuous, meaning the beats are evenly spaced on the ECG. A key characteristic is the inverted P wave, which may appear in different positions on the strip before the QRS complex, with a short PR interval of 0.10 seconds or less after the QRS complex, or hidden within the QRS complex, making the P wave not visible at all. Despite the variations in P wave position, the QRS complex remains normal in appearance and duration, as the ventricles are depolarized through the usual conduction pathway. Now let's do a practice strip. When we look at this rhythm, the rhythm is regular and continuous, meaning that the beats are evenly spaced on the ECG. The heart rate is 80. I see 8 QRS complexes within my 6-second strip. 8 times 10 is 80. P waves. P waves are hidden in the QRS complexes. There are no visible P waves. PR interval is not measurable. Our QRS complexes are normal and are between 0.06 and 0.08 seconds. The ST segment does show a slight depression. This is an accelerated junctional rhythm. Accelerated junctional rhythm can provide provide valuable clinical insights when observed in patients as it often signals an underlying issue rather than being a primary diagnosis. Here are some common underlying causes: digitoxicity, myocardial infarction, especially inferior wall MI, electrolyte imbalance, most likely potassium levels, vagal stimulation or effects of certain drugs. Understanding these clinical implications can guide practitioners in identifying potential underlying causes and tailoring the management approach accordingly. Would knowing a bit more detail help you remember inferior wall MI as a common cause of junctional tachycardia? If you had this additional quick breakdown, do you think it would make it easier for you to remember? An inferior wall MI often triggers junctional tachycardia due to its effect on the blood supply to the AV node. The right coronary artery, which supplies the inferior wall, also delivers blood to the AV node through its AV nodal branch. When the RCA is blocked during an inferior MI, it can cause ischemia in the AV node, disrupting the heart's electrical conduction and leading to junctional tachycardia. Having this context makes it easier to link inferior MI to junctional tachycardia, helping you remember it more effectively. To explore more insights like these and access additional context clues that enhance your learning, join the NovaMind membership. You'll receive exclusive content designed to expand your knowledge efficiently. Join us on YouTube or visit www.novamindllc.com and click on membership to unlock premium content that makes learning easier and more effective. Often, accelerated junctional rhythm does not require treatment if the patient is asymptomatic. The rhythm itself is typically not life-threatening. If the rhythm is associated with hemodynamic compromise, treatment may involve addressing the underlying cause or rate control. In change to bradycardia, atropine, and in some cases, temporary pacing may be required if cardiac output is affected. Understanding these clinical implications can guide practitioners in identifying potential underlying causes of accelerated junctional rhythm and tailoring and managing the approach accordingly. Next, we are going to talk about paroxysmal junctional tachycardia with a heart rate greater than 100. Paroxysmal junctional tachycardia, or PJT, is a rapid heart rhythm originating from an ectopic pacemaker in the AV junction. With rates typically exceeding 100 beats per minute, this rhythm is often initiated by a premature junctional contraction and tends to start and stop suddenly, which is why it's referred to as paroxysmal. PJT may present as a sustained ongoing rhythm or occur intermittently in short bursts or of runs of 3 or more beats. Paroxysmal junctional tachycardia ECG characteristics. The key characteristics include that heart rate that exceeds 100 beats per minute. P waves can appear before the QRS complex with a short PR interval of 0.10 seconds or less, follow the QRS complex, or be hidden within the QRS complex. The QRS complex remains normal in width, indicating that the ventricular conduction is proceeding through the typical pathways despite the abnormal pacemaker location. Abrupt onset and termination, PJT often starts and stops suddenly without warning, which can be seen on an ECG as a sudden change in rhythm. PJT is frequently triggered by a premature junctional contraction, leading to an increase in the firing rate of the AV junction. Differentiation from other tachycardias, PJT can be distinguished by its inverted P wave, normal QRS complexes, and rapid onset and offset, setting it apart from other supraventricular tachycardia. PJT can be associated with several underlying conditions and triggers, including digitalis toxicity, excessive caffeine or alcohol intake, electrolyte imbalances, ischemic heart disease. Treatment for PJT is generally focused on addressing the underlying cause and managing the rapid heart rate. Interventions may include vagal maneuvers to slow the heart rate, medications such as adenosine or beta blockers, correction of underlying factors like electrolyte imbalances or drug toxicity. PJT requires monitoring, especially if the patient is symptomatic, as the rapid heart heart rate can affect cardiac output and lead to symptoms like dizziness, palpitations, or in severe hemodynamic instability. Let's do this practice strip. This practice strip has QRS R to Rs that march out, so it is a regular rhythm. There are 11 QRS complexes within the 6-second strip. 11 times 10 is 110 heart rate. There is one P wave before each QRS. The P waves are inverted, making it a junctional P wave. The PR interval is 0.10, which is short, and the QRS complex is narrow and normal in width. This is paroxysmal junctional tachycardia. Some common causes for PJT can be associated with several underlying conditions and triggers, including dig toxicity, excessive caffeine, or alcohol intake, electrolyte imbalances, ischemic heart disease. Now let's discuss the treatment for paroxysmal junctional tachycardia, PJT, in an ACLS setting. Now, PJT is a fast rhythm originating from the AV node with a heart rate typically between 100 to 180 beats per minute. It's often seen in cases of dig toxicity, myocardial infarction, or electrolyte disturbances. As with any tachycardia, determine if the patient is stable or unstable. Unstable signs include hypotension, altered mental status, and chest pain, signs of shock, or heart failure. If the patient is stable, follow the ACLS tachycardia algorithm. Vagal maneuvers may be attempted to slow down the heart rate, although this is more effective with sinus tachycardia. Adenosine can be considered if vagal cardio maneuvers are ineffective, especially if the rhythm is thought to be caused by the AV nodal reentry. Beta blockers or calcium channel blockers like diltiazem or verapamil can be used to control the rate if the patient remains stable and adenosine is ineffective or contraindicated. If the patient is unstable, example hypotension or signs of shock, immediate treatment is required. Synchronized cardioversion is the treatment of choice for unstable PJT, starting at a low energy dose and escalating as necessary. Medications such as amiodarone may be considered for ongoing rhythm control if cardioversion is unsuccessful. Address the underlying causes. Dig toxicity is a common cause for PJT. If suspected, discontinue the drug and consider antidotes such as dig-specific antibody. Correct electrolyte imbalances, example, potassium or magnesium, to restore normal rhythm. In cases of myocardial infarction, address the ischemia through appropriate cardiac care, including oxygen, nitrates, and other ACLS protocols. In summary, PJT is treated based on the patient's stability. Stable patients may respond to vagal maneuvers, adenosine, or rate control medications. As we wrap up episode 8 on junctional rhythms, thank you for joining us in exploring these unique rhythms that originate from the AV node rather than the SA node. The heart's conduction pathway really does take us on a fascinating journey. Looking ahead to episode 9, the disconnect between atria and ventricles, AV blocks. You'll gain a solid understanding of these blocks and learn how to identify them quickly, even under pressure. AV blocks can seem tricky at first, but once you know the right approach, they're among the easiest rhythms to interpret, especially in critical situations. For members, we offer a lot more, including extra practice strip, an in-depth look at ACLS guidelines, and quick tricks. You'll also find a tips section which teaches a fast 3-second method for diagnosing AV blocks in emergencies, turning them into one of the most easiest rhythms to spot and analyze. AV blocks aren't hard. They just need to be taught the right way. Don't miss out on these extra resources. Become a Novamind LLC member to sharpen your skills and get exclusive insights that bring real confidence to your rhythm interpretation journey. See you next time. Pause to read references used.